myself off the floor.
Welcome to Difficult Conversations About Beauty. My name is Anita East, and I'm a nurse practitioner specialising in aesthetic, skin, and integrative medicine. I'm so delighted to have you here. But can I get you to do me a favour and just look around you out there? It can be super confusing trying to work out what's true and what's not in this world of beauty and health. So during each episode, we seek to dispel the myths, find the truth, and empower one another with ready-to-implement advice that will make your life so much better than before you started listening. Just as a reminder, the podcast is not intended as a substitute for the medical advice of legitimate healthcare practitioners. The listener should regularly consult a healthcare practitioner in matters relating to their health, particularly with respect to any symptoms that may require diagnosis or medical attention. Thank you so much for listening and enjoy. I am so excited today to be interviewing on Difficult Conversations About Beauty, the wonderful Dr. Julia Diana. Julia, welcome.
Thanks so much, Anita. It's a pleasure to be here. I feel like we're old friends. They go way back now.
I know we go at least back a year now, don't we? So you and I are part of the NSS Scientific Advisory Committee for 2023, and we're excited enough to be part of it for 2024, aren't we?
We are, and we've got lots of ideas kind of brewing and lots of good things that we want to inject into the conference for next year. So I'm excited.
Love that pun, inject into the conference. Oh my gosh.
I didn't see that one, but yes, I did. I walked right into it, didn't I?
You did. You did. We are going to, as a team, we're going to make NSS 2024 quite incredible, which we're very excited about. We've already had our first meeting, haven't we?
We have. It feels like it was just yesterday that we were actually at the NSS. I can't believe there's less than a year to go before the next NSS, but it'll be good. It'll be a great meeting, as it was last year, and hopefully even better this coming year.
Absolutely. And I think that's it's important for people to understand, the amount of preparation and dedication that goes into these meetings. And, you know, as part of the Scientific Advisory Committee, we start kind of preparing, September? So we start preparing a good 8 or so months outside of the meeting to get it spick and span and perfect, and a wonderful experience for both experienced and novice injectors, and also novice people and experienced people in the whole industry of skin and non-surgical cosmetic medicine and dentistry, and also surgery as well.
Well, it's all about collaboration, because I think that sometimes it can be a bit intimidating, especially if you're new or perhaps you don't inject at all, and just trying to work out how we can all collaborate together, because at the end of the day, we're all focused on getting a result for our patient. And sometimes we do realize that it's not just about us. There's a bigger team, and we can all obviously refer to one another, because at the end of the day, we want a great result for our patient. So
absolutely.
I think that, the NSS helps to open up some of those channels of even just knowledge, of knowing who to refer to and what we all bring to the table. So I think that's probably one of my favorite parts of NSS, just networking and finding out about, other people's scope of practice that we might not have necessarily been fully aware of before.
The learning that you come away with, the actual bits of, I've been going to NSS since, I think my first one was in 2009. Or even earlier, 2008. And I come away from every single one having learnt something that I then implement into my practice, which then benefits my patients. So essentially, we're all about, like you said, patient care and getting the best outcome for our patients.
My first NSS was just 2019, because my journey's been a bit different because I'm a dentist. But anyway, go ahead, Anita.
Tell us, therefore, about your journey.
So my journey into, skin started with cosmetic injectables. I was sitting at a lunchtime Sunday roast at one of my friend's house, who happens to be a oral and maxillofacial surgeon. So very qualified, and we're going back to, I'd say it was around 2000 and maybe 11 actually. And he said to me, I think you should look into this Botox thing. And I looked at him like, are you crazy? What are you talking about? Because back at that time, it was a very kind of taboo subject when it came to dentistry and our scope, because there was no predetermined area for injectables within a dentist scope. And I said, what makes you say that? And he said, well, number one, I think you'd be good at it. But the second thing is that there was a court case that just went through actually in the US. And what happened was we had a patient that had a gummy smile, and her way of dealing with that was that she went to her dentist, who referred her to the orthodontist, undertook many years of treatment, because there's normally a couple of years of orthodontic treatment followed by some oral and maxillofacial surgery, because often gummy smile is related to having excess maxilla. So she had a maxillary impaction followed by another 12 months of orthodontics to complete the case. So all up, this is 3 years, and it's not easy treatment.
No.
And the treatment was successful. Everything went really well. But what ended up happening was this patient, caught up with someone who she hadn't seen for a while, and told this friend all about the journey. And the friend said, why didn't you just get Botox? And that was a jaw-dropping moment, because she's like, hang on a moment, I didn't know that that was even an option. And so she was able to sue successfully, not because anything went wrong, but because she successfully argued that if I had have known about this as being a treatment option, I would have done that. This held me back in my career. My relationship broke down, all the things that come with an invasive treatment plan. And so I think that, from that particular moment, that Sunday afternoon, I thought, you know what? This guy's got a point. I need to be telling patients about this, because if there is a way of being able to offer my patients a legitimate treatment option, which has low morbidity, low cost, low treatment time, why wouldn't I do that?
Absolutely.
So from that particular moment, I didn't actually realize what I was stepping into at that point. I thought, oh, I'll just go learn about Botox.
Yeah.
I'll
just do a little bit here, a little bit there.
That kind of
tip
thing.
of the iceberg.
And then, me being me, that's not what happened.
No, feet went first.
I went and undertook this entire journey I just never saw coming, but I loved it, so I had to keep going. And still, I go to the NSS not just to be part of the committee, it's part of learning and, increasing your scope and finding out the latest and greatest. But it was that moment on a Sunday that literally changed the course of my career.
Wow. And is that oral maxillofacial surgeon still operating to this day?
Unfortunately, no, Anita. Life takes unfortunate turns. So he was a mentor for me. So he passed away
I'm sorry.
Prostate cancer.
Yeah.
So guys that are listening, please go get your health checks.
Yes,
because it was
absolutely.
such a preventable thing. But we all get busy with life and so on.
Yeah.
But he changed my life in many ways. That was just one of them. But from that particular moment, I really can thank him, and I often do talk about him when I'm teaching myself, because it really did change the way I viewed even a consultation. It was a big curve, which I didn't see coming, but I'm glad it did.
And what a beautiful way for you to, he was your mentor, and then he suggested something, and maybe if someone else had suggested it, you might have poo-pooed it. You might have said, no, I'm not doing that. Whereas because he did, and he obviously saw your talent in terms of teaching, your talent in terms of picking up new things and going feet first into something and really making the most of it, then what a testament to him and his memory as well.
Yeah, look, he was very inspiring in many ways. And to be honest, when I first met him years earlier, I was kind of a little bit, scared of him
Scared.
in
I
a
knew you were
way.
going to say, yeah, in awe.
Because
You were
yeah,
in
because
awe.
he was just so smart. And I mean, to be a max vax, that's not just a couple of years. That's like a dedication of your life to the cause. And I always saw him as someone who like knew an immense amount of knowledge, and especially about the TMJ, for example. So it's an area which I always have an interest in because I'm a dentist, but because he inspired, or he lit that spark for me before I even became a dentist. So I was in surgery with him at one point, and he just changed my view on consultations and the way you assess a patient. So I will forever be thankful, and hopefully try to inspire others as he inspired me.
Lovely. So you got into, the spark was lit in 2011. When did you actually start? Because I'm really interested in when you started your career into injectables, and then when you actually started your training academy.
So at that point, I looked for someone who was willing to teach me. And this was actually one of the hardest things, because I was a dentist. Everyone kind of washed their hands of me at that point because I was in the too hard, too grey basket. So I did find
and we'll talk about that in a moment as well, because that's a really interesting thing, because I still have people saying to me things like, oh, dentists can't do this. And I'm like, yes, they absolutely can. And their knowledge of the face and, and the head and neck is superior to many, many, many others.
And you know what? Even just assessment and dexterity. So, that's a whole other conversation, which I'm sure we'll have.
Yeah.
So anyway, I found a course provider that would actually provide me with knowledge. And so I went with that for a couple of years, where I was injecting people and so on. And then I guess I wanted more. So that wasn't enough. And so I went and did dermal therapy. So I thought, you know what, I'm going to back myself, because I want to know that if I'm working with skin, I don't just know about injectables. I need to know, what does pigmentation look like? What are the different solutions for this? I don't necessarily need to provide those solutions, but I need to understand skin enough that I'm not just injecting without thinking about it. I really want to understand the levels I'm injecting at, and so on. And so I just kept going. So I went back to university and I did that. And that was, it took a lot of dedication, but it was, I think, for me, worth it. I've had a bunch of different challenges along the way through AHPRA and, just again, being able to find someone who was willing to take a bet on a dentist. So that was probably some of the biggest challenges, but all those challenges have made me stronger. It made me believe in myself and made me work harder. So I don't see them as a negative experience, although they might have been negative at the time.
So you must have been one of the first dentists to really kind of get involved in injectables then, alongside your dental practice.
Yeah, I was pretty early on, and because I did understand that it was kind of grey. Like, obviously I was sticking to, head and neck, which is my speciality, but I knew that, there was no real ruling at the time from the dental board. They had some provisional statements about it where they kind of inferred that, we could venture into this path, but it was provisional. And so I didn't really, I guess, promote it. I might have had a couple of lines on my website to say that this was part of my practice, but I didn't really promote it too much, because I didn't want anyone to take aim at me without knowing me.
And without knowing the work that you'd put into becoming skilled at injectables.
Yeah, and I think that on the face of it, sometimes when people have objection to dentists injecting, and you know what, this is not just a dentist thing. It can be for nurses, it can be for derms, or whichever speciality. There's always people that like to pigeonhole everybody, and also apart from that, they're worried about potentially dentists stepping on their turf. whatever the turf is, in that
Mm,
everyone likes to have their piece of the pie and not
mm.
necessarily share that. But I think, look, we've all got something to offer,
Yeah,
and
which
we're
is
all,
very different to every single other clinician and practitioner out there.
yeah, and we're all coming from a different way of looking at things. I mean, primarily my foundation core skills are dentistry, but I obviously incorporate looking at facial assessment every day. That's part of looking at orthodontics. That's what we
Mm,
do.
mm,
And looking at
mm.
symmetry and that kind of thing. And I work with, pharmaceuticals every day. I'm injecting people every day. And I'm not talking about necessarily, using toxinal fillers. I'm using pharmaceuticals
Yeah,
every single day
yeah,
and trying to improve the health and appearance of someone. This is just an extension of that. It's not
absolutely.
replacing what I'm doing, it's an adjunct.
Yeah, absolutely. Absolutely. And I do want to come back to what you think has been the greatest advantage to being a dentist in injectables, because I know the presentation you did at NSS about this is what dentists know about the face, and this is why we make good injectors too. And I was floored by the level of the actual amount of information and detail that you know about the face that I don't know.
I think that the hardest thing about giving that presentation at the NSS was I had so little time, and it's such a
Yes,
broad area.
I
So I've
know.
just tried to pick out the key points, which
And you
is
did.
that, well, I tried, so
Yeah.
I'm glad that came across. But I think that as a dentist, I'm primarily interested in bones. So that, foundation structure. And I see the teeth as being part of the bony structure. So if we think back to Brian Mendelsohn, when he did that kind of groundbreaking paper where he
Mm-hmm.
started talking about the changes that happen in the skeletal structure as we get older, that's connected to dentistry. This is what I see every day. And
Mm,
so to take that knowledge and to apply it to cosmetic injectables is very powerful, because instead of only being able to offer, those high morbidity treatments, let's do orthodontics, but it's going to involve some surgery to get you there. Not everybody wants that. And
mm,
so we have to open it up, because if they don't get it with me, they're going to go to someone else. And it's not me stealing turf, it's me understanding what's going on deep down, the tooth structure and so on, and being able to use my knowledge to make things better for that patient.
mm,
And
mm,
so apart from looking at, the bones and teeth, obviously we've got all the soft tissue that's draping over the front of that. And again, going back to being able to provide options for the patient. So if I have a patient that has a really recessed chin, my only option without injectables on the table is orthodontics and surgery again. And you know what? Not everybody wants that.
No, and
Or
surgery is, looks, these
huge,
days,
Anita.
surgery should be a last option.
Well, looks primarily as you're a younger patient, it probably would be the option to choose, because you can prevent a life of, potentially getting cosmetic injectables and so on. So we've got to, balance, where the patient's at in their life with, what do they actually want. But the thing is, when it comes to injectables, it needs to be an option. It
Mm,
needs to be, because not everybody, even after surgery, gets the full correction
mm,
of,
mm,
whatever it was that they had a deficit in. And
mm,
so my, I guess, view of looking after patients is that I want to be holistic. I
mm,
want to provide a good service to the patient. I want to give them options, and it's not just about the traditional options. It's about opening up everything that I should be opening up for that patient, because if I need to project the chin forward, there's more than one way of doing that. And I keep using
mm.
the chin only because, dentistry
Yeah.
and chins, it's very relevant.
Yeah. And
Yeah.
it's right there. It's right there at the pretty much forefront of our face. And it's important for a lot of people, in terms of the balance and not the symmetry, but the balance of their face.
And symmetry too. Yeah.
Yeah.
And even sexual dimorphism. So,
Yes.
males should have a wider chin than females, for example. instance, we lose teeth. That can happen as you get older for whatever reason. Maybe you fell over and hit your chin and a tooth died and it can't be saved, or what have you. Sometimes we have tooth replacement options that still result in bone loss, and so surgery is not going to give that back to us.
No.
So we need to be able to provide a level of care which is beyond just the traditional options.
Absolutely. I had a patient not too long ago who had a chin implant, and she's in her 40s now, and she'd had the chin implant in her 20s. And while it was fantastic for, I don't know, 10 or 15 years, now that she's in her 40s, her mid to late 40s, she's finding that because the rest of her face is aging, that it doesn't sit well with the rest of her face. So it stands out for all the wrong reasons. And that's something that and because it was such a long time ago that she had it, she's unsure of what it's made of. She's unsure of, the margins of it. I could feel it and so forth. But in terms of injecting around it, I have to be very, very careful.
Yeah, it presents a bit of a problem, because obviously the correction of a surgical implant is probably removal with another surgical implant.
That's right.
And so if the patient's on that journey early on, it limits where they can go in the future, as you know.
Yeah, Julia, can you tell us about your training academy?
So this is something I'm very passionate about.
I know, I love it.
I've been in education for approximately 8 to 9 years now. So initially I did my training. I had passion for it. I felt like I was good at it in sharing knowledge and so on, because I thought, what, I went through a hard time. So I want to try to make it better for the profession as a whole. And so for the first 4 years of me educating, it was primarily to dentists, because that's where I was allowed to be. And then a couple of years after that, I was working with a medical doctor. And some of the reasons that I left those organizations was I just felt that probably there was better ways of doing things that might be, I'm trying to stay a little bit politically correct here.
Yes.
Not so biased towards financial reward.
Okay.
And so I felt that what I wanted to do with my education was open it to anyone. So, doctors, nurses, dentists, anyone who legitimately can inject.
Yes.
And I wanted to present scientific information, much like the NSS. So I take, bits from here and there and try to bring it together in a non-biased, non-brand focused way. And I'm very open about affiliations that I have, which doesn't always happen. But I make that happen because I think that you need to be open and try to provide really solid information. And to be honest, Anita, if COVID hadn't have happened, my training academy would not be set up the way it's set up. So in some ways, that was a really good time for me, even though it was really difficult.
It's really interesting. I interviewed James Vivian the other day, and something that he said, which was pretty much identical. Now, you're both based in Victoria, and we know that poor Victoria copped lockdown. It was like Groundhog Day lockdown, wasn't it? It just continued day in, day out. And what James did was he essentially launched into the version of himself in terms of his business and his skin clinic, James Vivian, as a result of having to go, what am I going to do? My clinic is closed. I'm a physical hands-on physical touch clinic, and I'm closed. What am I going to do? So it sounds like Dermal Distinction Academy was created in the same manner. So tell us about it.
In the first lockdown, which I think we were all Australia-wide, we were in that one. So I think, how long did that last? It was about 6 to 8 weeks, something like that. So in that 6 to 8 weeks, I was just working on things within my practice, as in, I've been meaning to paint that, so I'll do that. But then lockdown 2 happened. So that was September through, it lasted what seemed like forever.
10 years.
And that lockdown, I think for me was the hardest of all the lockdowns.
Oh,
I
dear.
mentally was probably not in a good place for
No.
probably not too long. It was about a week or so where I'm like trying to figure out what am I going to do, because the rest of Australia is not in the lockdown with us, and there's no potential end date. So what am I going to do? And I thought, you know what, traditionally when I was presenting cosmetic injectable information and education, what I was doing was I would present for a day, and then the theory and so forth was all presented in that day, and the second day people were injecting. And when I kind of look back to that model, which is still the way a lot of injectable education providers still run things, it's probably not the best, because you only have a day to absorb the information, and it's often not enough because you don't get time to even think through questions that you might have as a delegate. So I thought, you know what, I'm going to pivot and I'm going to start making a huge, really robust e-learning. So a lot of e-learning. And so that's what I did. I poured months and months. And you know what? Actually, during normal hands-on clinical time, I actually worked less than I did while I was in lockdown, because I'd wake up in the middle of the night with a bright spark. And I'm, you know what? I need to put that into a module. I'm going to write that. And so at 3 a.m., I'd be literally sitting at this desk right here. Writing up more info. So I've got huge focus on, anatomy and the theory. When we were allowed to, I filmed, procedures. So we've got really, really good visual of, up close and personal of what inject a masseter or a lip or, whatever it is. But that's what I poured lockdown to, and I've not stopped. So anytime a new piece of information comes up, or a groundbreaking study comes out, and I think I need to tell my delegates about this, so I've got to incorporate it into the e-learning, or the after, the course modules that happen after. So I do that. So I think I like to think that it's one of the best out there, because
it's great. I've looked through your content, and I must say it's so thorough. And we were talking about new injectors and even experienced ones who want to refresh.
Yeah, and I think the other thing that I've tried to focus on is, for instance, I mean, you're an injector too, obviously, Anita, but when you're looking at doing a cheek, there's no one way to do it. There's 3, 4, 5 different ways of doing it. It could be a needle person or a cannula person. So when I was going through and doing the e-learning and filming the videos, I was filming it multiple ways. And writing the theory for multiple ways of doing it, because there is no right or wrong.
And that's what I love about it, because a lot of people think that there is only one right way to do things, and there isn't. There really isn't. And especially not in injectables, because as long as the principle is maintaining safety at all times, and we know what those principles entail, there are multiple ways to, I hate to say it, skin a cat.
Yeah, and I think, look, the other thing also is that you always have to base your injecting decision on anatomy. That's got to be number one. And it has to be also what's best practice. So you can't come up with a novel way of doing something that no one's ever been done before, because that's cowboy stuff. But you need to look at what's been researched and studied, and what our peers are doing, and you pick out whatever works for you and what works best, and maybe whatever is most applicable to the patient that's sitting in front of you as well.
We're as healthcare practitioners, we are naturally, whether it's innate in our being or we're learned, critical thinkers. So essentially, if we are presented, we absolutely should be, shouldn't we? When we are presented with a new way of thinking, we can certainly critically analyze those pieces and work out quite quickly if they're cowboy stuff. If it's like, oh my gosh, well, you've immediately jeopardized the patient's safety by doing A, B, and C, so the rest of this study is going to be, rubbish. Or this is like, oh, that's a really interesting way to look at that. And I think that's really important when people are choosing their injector, is finding someone who's interested in lots of different types of methods of application for injecting and skin treatment as well.
I think so too. Recently, I spent some time with Lee Walker. I think it was back in August.
Mhm.
And for those of you who don't know Lee Walker, he's basically a global expert on complications and injecting all sorts of different things. And I was lucky enough to spend a day with him, and we weren't injecting at all. We were
Mm.
just critically reviewing journal articles.
Oh, that's my heaven. I would love that's how heaven sounds to me. I just sit there
Yeah.
reading journal articles and saying and yeah, critiquing them.
Which was actually quite interesting, because I think that I do that without thinking about it, but sometimes you're almost too scared to say it out loud that, this journal article is flawed for this particular reason. But as a group, we were coming together and looking at the journal articles. So this is quite topical and maybe even a little bit controversial, because just yesterday there was a
Oh, yes.
the article.
Codafana.
Yeah, that's the one. And
So interesting.
yeah, I thought that I haven't read the study. I've
Me
read
neither.
the abstract so far.
Mm-hmm.
And I think that just based on the abstract, I probably would pick that apart quite a lot at the moment. Because I understand what they were trying to do with that article, but I think that I was reading, as you do, you become a bit of a scroller, and you come here sometimes just for the comments. And I don't know if you read any of them, Anita.
I haven't, but I did see someone screenshotted something from a quite prominent doctor in the UK. But for our listeners, yeah, right. For our listeners, Sebastian Codafana is an anatomist, isn't he?
He is.
He's like the guru. He's a guru in our
well known.
Very well known
Very well
in
respected.
our world. Absolutely. And he published yesterday an article basically stating, and I'm trying to get this as concise as possible, that if you continually move your needle, and it was needle, it wasn't cannula, wasn't it?
It was definitely needle.
Needle.
Yeah.
If you move your needle constantly, then you're increasing the risk of a vascular injury. And in that, because what we do, so research up until this point has said, if you move your needle constantly during injecting dermal filler, not toxin, this is dermal filler, then it's safer for the patient, because if you are, for example, sat in a vessel and you're injecting and you're just staying still while injecting the dermal filler, then you're at great risk of increasing the risk of a vascular occlusion or a vascular injury. Sebastian has come out and rubbished that completely and said it's not true. And he's got all the, the fancy graphs to show that it's actually less safe if you constantly move your needle while injecting. So this is like a bomb going off in the world of healthcare practitioners in non-surgical cosmetic medicine, wouldn't you say?
Look, I think a little bit, but if we're being really critical, just going back a few years, so the reason why we all move our needle, so if we start with that, is there was a global consensus group who came together and looked at broad studies and determined that when we're looking at complications, it's generally because someone's injecting a volume of dermal filler in the one spot, unknowing that they are actually in a vessel. So the global consensus group, which again was some very, I guess, internationally recognized, very peer-reviewed experts in the field, who made this consensus for patients to be safer. So I think we've all looked at that study and understood the benefits of doing that. And so when this was released yesterday, and I was reading through the abstract, the thing that I noticed in the title of that particular article was it was a mathematical conclusion.
Yeah.
And so that in itself for me has a bit of an alarm bell on it, because it doesn't correlate necessarily to patient treatment, because mathematics is one thing. What we need to then do is take that hypothesis and actually apply it to patients and look critically, if you did stay in the one spot, does that actually make it safer for patients? Because The problem is that if you are in a vessel and you just keep injecting in that one spot, that I can understand how that is a problem. And then I was also looking at those pretty graphs that you mentioned, Anita. And one of the things that I noticed was when he was talking about, moving your needle, if you imagine this is skin and then this is the needle, I'll just move my hands up, you're doing this. So you're creating basically a cone with your needle, and I don't think anyone does that.
I must admit, and what we'll do is we will put a link to the study. And for those of you who are wanting to, you can actually watch the video of this interview with Julia on YouTube if you want to actually see in terms of what we're doing. But we're saying that the representation of what was said that we do with our needle isn't 100% accurate. And I think that's actually when I stopped looking through the post, because I thought, oh, well, I obviously need to look at this more thoroughly, because I certainly have never sat there and stuck a needle in and then waved, right? And kind of
done circles with your needle. No one does that.
No, mine's more in and out.
Yeah, so, traversing through, and normally we're placing threads in the tissue to create like a support and a structure. I don't think, well, at least not in my experience, that there's any injector that would put a needle in and then just swirl it around
swirl it around. That's the right word, swirl.
Which is what was being illustrated in the article. And I thought, well, it's a mathematical conclusion that I don't think I quite agree with at this point in time. I think maybe it's just a stepping stone into actually the need for more research.
And I love that. Yeah. How good is that? How good is this? The fact that we're talking about it, and gosh, on his post, on Sebastian's post, oh my goodness, I can only imagine the amount of comments that are on there. So how good is that we're talking about it with our goal being patient care and patient safety?
Yeah, well, I think that we all need to be thinking critically as injectors, but, as patient too, about what does my injector know and what do I know as an injector. And you should look at articles that are written by notable people such as Codafana critically, no matter who they are, because you need to understand what it is that you're reading and not just take it on face value. Is it,
that's right,
a patient related study, or is it mathematical as this one was?
Yeah,
so I think
absolutely.
More in this space will eventuate.
Yeah, to be continued on that space. So. Hey, now Julia, I want to touch on the new. Well, I say the new AHPRA guidelines that were released on the 1st of July, but funnily enough, a lot of those guidelines in terms of advertising and the TGA ruling have been present since 2016. So a lot of those aren't actually new, but in terms of, not allowed to do glitzy befores and afters that are in different lighting, that don't that are to music, and that are all of that kind of thing. How do you think that the public and healthcare practitioners who are working in non-surgical cosmetic medicine have moved on with this information from the 1st of July?
This one's one that's dear to my heart, and I know that you and I have bonded over this one a little bit.
Yeah.
So the thing that I found, I guess, the most difficult was that after the NSS, obviously we had the experience of kind of hearing from AHPRA themselves about, how this is going to work and so on. And so I thought, for those that weren't present, I'm going to share my knowledge with people. And so what I ended up finding was that in some areas where I reposted, hey, look, everyone, this is what's happening as of the 1st of July, get your house in order, make sure that you abide by these guidelines. A lot of, I'm going to poke a dentist because I am a dentist. I don't think I have ever received such negativity ever by dentists just saying, this doesn't apply to me. This is for medical practitioners only. And I think that we have to be a bit smarter than that, Anita, because, I'm a dentist, I'm an injector, and I hope that I never have to sit in front of AHPRA to do a please explain about, something that's happened. But should that happen, I really don't think, if you're smart about it, that AHPRA is going to say, oh, okay, Julia, the rules for dentistry are going to be this, but the cosmetic injectable part that you did, those rules are different. So we'll just apply what we think to the injecting part, but the dentistry part, no, you're fine with that. I don't think that's the way AHPRA is going to rule the roost.
No.
And I think that's going to be tightened up further this next 1st of July, where the boards will come together and make a consensus that the rules are the rules, no matter who you are.
Absolutely, because there was a little bit of, that doesn't apply to us, because
Yeah.
it was Anne Tomkin who came to NSS and kind of clarified some of the rules and regulations for us. And then a lot of people were updating that on their socials and so forth. But because she's the head of the MBA, which is the Medical Board of Australia for AHPRA, I heard people saying, "Oh, that's only doctors, that's not nurses," and it's like, no, it's all of us. We are healthcare practitioners. She came along to clarify some things for all of us.
Yeah, look, I think that everything's fine when things are fine, right? It's when you have a problem that you're like, whoa, hang on a minute. Now I've got to scramble to get my house in order. I like to sleep at night. And I've always thought that, a testimonial is a testimonial. And there are some things like, for instance, lighting and so on, which have been in place for such a long time, as you mentioned. And I think that, as of the 1st of July, AHPRA has been given a good sizable budget to now kind of enforce this. And they've done this because of the industry kind of having been a bit out of hand. And they're trying to make, again, I guess practitioners look at what they're doing and kind of draw up new rules, which largely aren't new. But they've helped to refine things. So one of the great things that came out of the 1st of July was there was some advertising examples that AHPRA published. I think it's actually the first time they've published, at least in my experience, I don't think I've ever seen anything like it before, where they literally said, okay, this is okay, this is not okay.
Not okay. They spelled it out.
Yeah, which is actually, I think it's good because it takes away question of, like, for instance, the use of emojis. That one's a huge one. But we all know that we use emojis to lighten the mood or to soften the message we're saying, but actually we shouldn't be softening or lightening what we're saying, because sometimes some of the procedures are risky. And for us to soften it with an emoji, I think takes away from, look, who we are as health practitioners anyway. We're doing serious things to people.
Absolutely.
And patients, I think, sometimes get into the space where they think, oh, this is just a lunchtime thing, it'll be fine.
This is just like getting my nails done or getting my hair blow dried or something.
It's not.
Yeah, it's not. It's completely not. I do still see, even since the 1st of July, I feel like there was a bit of a hiatus in terms of some accounts just didn't publish anything. And then recently, I'd say over the last month, I'm seeing all the same culprits doing all the same mistakes in terms of using emojis, using emotive language. Oh, she was really tired and unhappy beforehand, and then the post photo, and how beautiful it is, this filler, without explanation of what the procedure was, which is what we need to do as well. And also the caveat in terms of, every patient is different and you require a healthcare consultation. I see all the same mistakes being made again. And I think it's a case of, it's like the child who gets in trouble from their parents or their carers and told not to do something. And then they kind of they don't do it for 5 minutes. And then they test the water and go, oh, mum didn't see. I'm going to do it again. It's kind of, that feels like what's happening out there right now.
Yeah, I think my take on it is that, look, AHPRA's had a lot to deal with. Because obviously, 2022 was a big year when it came to exposés on
Four Corners and ABC and
60 Minutes and all that sort of stuff. So I think that at the moment, largely the focus has been on cosmetic surgery. But I think that AHPRA just made the announcement just a couple of weeks ago, I think.
It was.
Yeah, that the 1st of July next year, the focus is going to be on cosmetic injectables. And I feel like that's almost AHPRA's warning of like, we're giving you a year lead time to read the rules that have already been published.
Yeah.
get things in order, because as of the 1st of July, 2024, we're going to be not focused so much on cosmetic surgery, because I think largely they will have cleaned up a lot of that. And the focus is shifting. So get ready and pay attention.
Yeah.
I think that's kind of almost why they've given us a bit of a warning and a bit of a lead time, because it's published already.
Yeah, totally. And I love
Yeah.
that. I love that. It's almost like, I'm warning you, sort it out, or we will be fining. And I did hear that there was a $60,000 fine issued maybe a couple of weeks ago.
Wow, I haven't heard that.
Yeah. And it's like, oh, that's there we go. They're actually, and again, for listeners, this is not about, waving the naughty finger at healthcare practitioners. This is about keeping you guys safe, keeping the public safe, so that we have a systematic regulation that all healthcare practitioners in the area of non-surgical cosmetic medicine are following.
Yeah, I think it'll be interesting to see what happens in the actual dental space as well, because I know a lot of this is focused on, the outside aesthetic appearance, but with dentistry, I've been saying it for a long time, with dentistry, largely what we do is irreversible. Once we cut a tooth and, put a veneer on it, that's a veneer for life. So the patient's brought into that treatment forever.
Yes.
And so at the moment, there are some practices and Instagram accounts which are all about influencers. They're all about everything that AHPRA is focusing on in the, it's quite daunting, because I think these were the people that kind of arched their back up and said, no, this doesn't apply to me, because it would wipe out their entire website and their Instagram.
Right. Interesting, isn't it?
I think that, when we're thinking about things critically, I mean, if we're looking at Botox, we all know that Botox, give or take, lasts about, 3 months, give or take, for individual variation. A veneer lasts for life.
Yes.
And so once I do that body modification procedure, which is essentially what it is, right?
Yes.
That's for life.
Because you're changing the actual structure of the person's original tooth.
That's correct. And I think that sometimes those things are done in a way, and this could be a whole other episode.
I know. Oh my gosh. I know. And I'd love to talk to you about veneers one day, because I think the whole thing is very fascinating. And maybe we'll talk about veneers, because I don't know much about it, but I do know. And certainly when I've seen veneers removed and I see what's left of the original tooth, it gives me a little bit of a chill.
Yeah, I think that sometimes those procedures are done too flippantly. Because as much as I was saying, not everybody wants orthodontics and so on, sometimes all people need is a bit of orthodontics, and actually they don't need veneers at all.
Yes.
And so I think that, when I am thinking about a patient and their treatment, I always do have their best interests at heart. I like to always offer all options, and obviously provide them with information that they can make a good choice for themselves. It needs to be informed. And I can see that one day AHPRA's focus will be on dentistry. And to be honest, I think it should be more so than some of the other things that they're focusing on at the moment, but they'll get there.
Absolutely. And I
know
think
she mentioned, Anne Tompkins mentioned dentists on that day at the NSS.
Yeah, absolutely. And I think what's interesting is we've kind of covered what I wanted to discuss in terms of, when I say the good, the bad, and the ugly. Well, I think we've talked about the ugly in terms of, what's perhaps not very attractive about the profession and what we're getting wrong. So can you give us, in terms of the future, what is a piece of advice that you would give to our listeners to improve not only their health in general, but specifically related to their oral health, that we can all be doing after listening to this podcast?
I think one of the misconceptions with dentistry is that if it doesn't hurt, it must be okay. So that's not the case with fluoride. So fluoride's in most water in most cities these days. So fluoride's been an amazing World Health incentive where the rate of decay has significantly dropped. but in some ways it tends to hide what's going on until it becomes a big problem, because fluoride helps to make the enamel or the outer structure of a tooth nice and hard. So you can have a little problem kind of lurking between the teeth, and the tooth is otherwise whole. And so those 6-monthly appointments, they're not just, I was going to say lip service, but then that's another injectable type
Yes, you're good at these.
I don't even mean to be, but it's not just because, we feel like it. It's because we actually want to check, is there a little problem that if we corrected now would actually save a whole bunch of tooth structure, save you from pain. So don't think that because it doesn't hurt that there's not a problem. The second one is a message around vaping. So I've seen this a lot recently, and it's in some ways soul destroying, because just like I was talking about, fluoride was such a good World Health Initiative. Unfortunately, what I'm seeing at the moment is, especially amongst younger patients, so the cohort that are around 20-ish, 20 years old, massive amounts of decay again, which I haven't seen in my career. So, we're getting patients that have had no problems all of a sudden with like 12 decay spots. So this is like pre-fluoride stuff. And unfortunately, vapes are very unregulated.
Yeah.
And so there's a lot of sweeteners that are placed in them. There's a lot of acidic, I don't know what the flavors are in them. And I think that we're going to see a lot more in this space. So if you are vaping, maybe reconsider that as being a healthier alternative. It's not.
Yes.
We're seeing a lot of detrimental health things going on in people's mouths.
Yes.
And floss. That's my other one.
Oh my gosh, I love these. So number one is get to your dentist every 6 months for those checks.
Don't vape is
Don't
my
vape.
second one. The third one is floss. So 60% of decay happens between teeth. So if you're not cleaning that 60%, which is where flossing comes in, you're potentially going to have a much higher risk of decay. So we don't want that. And we also don't want gum disease. So gum disease is linked to, bacteria hanging around.
Yeah.
And so we don't want that as well, because there is a very strong link between gum disease and heart disease. So if you have gum disease, you're much more likely to have heart disease, because you've got a lot of bacteria that are basically growing in your mouth.
Yeah.
Your gums bleed, you're introducing that bacteria into your bloodstream. And if you have just a bit of a niggle going on with your heart, whether it be a bit of a heart valve defect or some sort of plaque in the heart valves or the the vessels, your chance of having heart disease is much higher. So for all those reasons, floss, don't vape, see your dentist.
Oh my gosh, Julia, that's fantastic. That is going to be a beautiful soundbite, that what you just said then. I love that. That's fantastic. Thank you so much. I have adored having you on Difficult Conversations About Beauty today.
Is this over already, Anita?
I know.
Do you
know that we've been going for nearly an hour?
Wow. No idea. That went really quick.
It went really quick, and there is so much, but I think I would actually love to chat to you another time on another episode about veneers, because I think that would be incredible, because certainly a lot of the dog's back. Certainly a lot of patients talk about it, ask me their advice about my advice about veneers. And of course, I don't have any advice. My advice is see your dentist and talk to them. But I do see a lot of people walking around with these brand new, every year I see these new teeth coming in, and I'm like, oh, wow, what am I missing out on? And then, because I've got a little bit of a crooked tooth and all the rest of it. And I'm like, I've never done anything like that. And I'm so glad I chatted with you about it at NSS, because, you kind of shone the light on a few things for me as well. So let's chat again another time about that kind of thing.
That would be amazing. That'd be fun.
But in the meantime, thank you so much for coming on. And I know that our listeners will love everything that you've talked about. We will be putting all of your information in the show notes. So information in terms of how to get in touch with you at your practice, but also how to enroll in the Dermal Distinction Academy. And people can have a look at all your training modules and so forth, plus your hands-on face-to-face training, all your socials as well. So I pop all that in the show notes, and I can't wait to see you soon.
Thanks so much, Anita. It's been fun.
Thank you. Thank you for listening. If you have enjoyed this episode, please share. Remember to give it 5 stars and write me a kind review. Remember, kindness always comes back to us. All discussed links will be in our show notes. And until next time, may you revel in your beautiful and unique faces, both today and always.